Okay, I have with me today Dr. Martyn Pitman. He will be known to many of you by now. He's been a guest on the channel previously on several occasions, obstetrician, gynecologist, and very much an advocate for Lucy Letby at this point as well. So without further ado, I'll say hello to Martyn.
Hi, Chris, and thanks very much for inviting me back.
No problem, great to have you here. So we're going to discuss several different issues today. The first of these are just a couple of news items that have occurred since the last time we spoke. So the first thing I'm going to ask you about is just this fairly extraordinary episode with the police where David Davis has made this speech in Parliament. I know for a fact that it's very thoroughly researched. I've fact checked it on this channel. We know that it's all correct. And then we saw this letter from Mark Roberts, Chief Constable of Cheshire Police. I would question how informed he actually is about the investigation, but certainly the letter wasn't terribly impressive. And then David Davis has given him pretty much a thorough kicking a day later. So I just wondered what you made of all that, if you have any comments on it.
It was an astonishing development from every angle, really, wasn't it? I was very, very pleased, delighted with David Davis's intervention in Parliament at the adjournment debate, and I guess like you, I was hanging on his every word, really, and waiting to see what he was going to say. And I thought he was, for the time he was actually given. I thought it was a very, very concise and astute summary of what had happened, given the complexity of where we are, really, and what's already happened in the Letby investigation and prosecution. Um, and I sat through it and I thought, well, yeah, this is all factual and essentially evidence based. So I wondered what the response would be. And it's interesting, isn't it, from the chief constable's perspective, he had essentially he had three options, and I think he probably made the worst one. The first option would be to do nothing. The second option, which was the one that he took, was to essentially double down and basically defend what they'd done. And it was, his letter that he wrote. Did he write it, or how much did he know about
Hmm.
the fine points of Operation Hummingbird, and how much of that letter and response was written by Paul Hughes? I suspect probably quite a bit. So astonishing, really. And you'd have thought if he was going to make a response, bearing in mind, at the end of the day, he's a civil servant, isn't he? Paid by the taxpayer, and somebody as high up in the police as him, you would have expected his response to be absolutely 100% squeaky clean and accurate, and it was very, very far from it. As we saw when David Davis came back at him and essentially eviscerated his response. The third option he had, which one would have thought would have been appropriate to consider, would have been, if he genuinely believes what he said and that everything that they did was above board and 100% guideline compliant, and it was an exemplary investigation warranting all of the praise that they got and the awards and everything else that followed on from that. The third response he could have had would have said, that's fine. If you've got legitimate concerns, so David, then more than happy. You decide who, and we'll open up everything and we'll give you everything you want. And we're very, very happy to be scrutinised. They'd said that they welcome challenge and they saw challenges as very positive. Well, demonstrate that, prove it,
Hmm.
and invite independent auditors in, or an independent organisation to come in and check what you did and to see whether it was appropriately done. Because that's very, very far from what he said, and he said he's not going to release the documents that Sir David requested. So, well, why wouldn't you if you've got nothing to hide? So I don't know where it goes from here. I don't know whether Sir David has the ability to call Roberts into for questioning in Parliament. I guess he probably does, bearing in mind that's essentially what politicians are for, isn't it? So I think it will be fascinating to see how this develops.
I
Uh,
agree. So I mean, I personally think that when they respond to something like this, it's not that they're really defending their investigation; they're just defending the public image. I think that the Wilmslow cases made a significant contribution to this. They probably would have responded anyway, but they're obviously smarting a bit from. There's been an ITV documentary calling them out on that case. Now they're being called out on this case as well. They've obviously David Davis didn't miss a beat on citing the Sally Clark case, where
Mm.
they obviously screwed up very badly as well. So that's three massive investigations in within a couple of decades. You'd hope at the most, well, ideally you get zero, but you'd hope at the most you screw up one investigation every 20 years, not three. And that's just three of the most prominent. So I think it's
Certainly,
becoming, to me, it's becoming very clear that local constabularies cannot investigate this type of case and shouldn't going forward.
mm, certainly chronologically, the broadcasting of the ITV documentary that obviously Stephanie Davis was involved with Wilmslow was it just predated all of this, didn't it? And I mean Stephanie hasn't certainly been shy in her criticism, has she? And good for her in view of what she thinks she uncovered, and the fact that she submitted a complaint herself, addressed to the very same person, DC Roberts. I would imagine with that, and then David's criticism, he was feeling a bit put out, really.
Mm.
Um, so I find it very hard to believe that he hasn't jeopardised his position, really. If any of this gets proven, that he's to make accusations of the nature that he did against a politician, a senior, and as the level of cross-party respect, I think that Sir David Davis has. I think Roberts has. It was a very, very brave, if not unwise, move, really.
Well, stupid, I would describe it as, because
Yeah.
if you're going to do that, you have to be right. You can't, if you're going to say, oh, everything he said is untrue and he should apologize in Parliament, if you're going to say that, you've got to be absolutely certain that you're correct.
Yeah.
Not, I've cobbled something together with Hughes and Stonier have cobbled something together for me. So that's not good enough.
No, I mean, as our esteemed leader, Mr. Storm, is going to find out next week. I think misleading Parliament is a pretty serious accusation to make against somebody. So
Yeah.
I will certainly. I'll be very surprised if Sir David takes that lying down, and I suspect there will be repercussions, and rightly so.
Yeah.
It's another interesting string to the bow of the Letby case, isn't it? Really.
Yeah,
So,
absolutely. And the other thing that we're going to talk about, which I know you have a real insight into, was that I made this video recently about the grievance and this new document that's been released. Now, I have no explanation for why it's taken so long to release this document, given that this happened 10 years ago, and the document obviously would have been available to thorough inquiry, and yet they've only published it. It's getting on for a year now since the public. Well, when did the public inquiry? In fact, is it over a year since the public inquiry finished? And they finally, how long does it take you to scan something and put it on your website? So anyway, I obviously did this assessment of this document, and there's some very important revelations in that. So I'd really like to hear your opinion on that and your take on it, really.
yeah, it's interesting, isn't it? This sort of scheduled release of documents from Burwell has been interesting, and I'd love to know the rationale behind that. And the cynic in me wonders if you like, the most potentially significant bits as far as documentation that is going to be useful for the potential CCRC application and potential referral up to the Court of Appeal, whether those documents, and I would put, certainly from my impression of this grievance episode, I would put that pretty high up on the list of documents that could potentially be very influential. And I guess unless you've actually worked in an NHS trust and realised how these things work, it's possible that you may not realise the true level of significance of what that episode represented. Because I think anybody who's worked in an NHS trust would realise that to submit a grievance as, let's face it, a pretty junior nurse. Letby was a band 5 nurse, wasn't she, when all this was happening? And to to have something go against you to the extent where you actually formally submit a grievance, but not only submit a grievance, but you're submitting a grievance against two of the most senior consultants in your department. That is an incredibly brave thing to do. And I was thinking about what would have happened before that would have been accepted and progressed, because I would imagine in most NHS trusts, if a nurse had decided that she was going to do that before probably it had the actual documentation had been formalised and submitted, I would imagine that one of her senior nursing colleagues or managers would have had a chat with her to make absolutely sure she was going to do it and the foundation for it, and she would have been told in no uncertain terms what a risk it was, and even if it didn't succeed, what it would mean for her ongoing professional position in that trust, and that could be and that it could be very much used against her as far as career progression and promotion and that sort of thing is concerned. So if she'd vocalized to her seniors what she was doing, I can have absolutely no doubt that they would have done all they possibly could to persuade her not to do it. So whether that happened or not, I don't know. But then she submits it, and I would have thought the moment that it had arrived on the management floor of the trust, then I would imagine the director of nursing would have been called into a meeting to say, crikey, one of the neonatal nurses has submitted a grievance against two of the senior neonatal consultants. Can you have a word? So she would have gone down probably to the lead nurse in the neonatal unit. They would probably have found somebody who Lucy Letby was close to have a word. And then, what I've just said would have probably happened if it hadn't happened before, but it would have been, are you sure about this? Because this could get really nasty. So one can assume that probably didn't happen, but I wouldn't be surprised if it did. But she still pursued it. So then it would have been the decision from the trust about who was appointed to hear the grievance, and that's a critical decision. And I know from my own experience that those decisions aren't made lightly, and they're very often deliberately made. So there'll be people in the trust who are sort of on side for the managers who are given the responsibility to do or to head up the investigation of such grievances. So that I don't know the setup here with the pharmacist who did it, but quite clearly they were very careful in how they did it. And I would imagine that, I might be wrong, but I would have fully expected that person to have been got at by senior managers in the trust to say, make sure, be a good lad and make sure that this comes out the way we need it to. So in other words, decide for the consultants and against the complainant. But that clearly didn't happen. And good on the guy for being honest about it, and for, because this, be under no illusion at all that Lucy Letby submitting that grievance against two senior consultants was the absolute prime example of David v Goliath, and for that pharmacist who oversaw the investigation of that grievance to side with David against Goliath, and to come down with pretty astonishingly fierce criticism of what was going on in that department, and investigating and recommending that further deeper investigations of what was going on and how the consultants were acting, and it appears the sort of toxic relationship levelled at Lucy Letby and presumably some of the others. That was incredible. And I can't help but think that and it's probably because there were, I doubt if the barristers or the judges quite understood the magnitude of what that achievement was. But for a junior nurse to actually get to submit a grievance, to go through the investigation of the grievance and to win the grievance against the consultants was unprecedented. Absolutely unprecedented. And let's face it, if the legal case against Letby hadn't have proceeded and then she was taken out and prosecuted and sent to prison, then there would have been ramifications for those consultants, without a doubt. And you could even argue that still should have been actioned and taken up, because if you're running a department where you've got consultants that your own internal grievance has found that they're treating junior nurses in that way, they're still in post, and you've still got junior nurses in that department. So who's to say that they're not going to carry on doing similar things to the nurses that are still there? So I don't think the barristers, and I certainly don't think Judge Goss realised the enormity of that achievement. And also, how can you possibly claim that with all of this going on in the background, with a nurse winning a grievance against those consultants and the potential ramifications of that wasn't instrumental in pushing Brewery and J around to do what they did against Lucy? Of course it was. It was highly relevant. It was highly, highly relevant. So I think it's like several things. One of the things we're going to come and speak about in a minute. The further that any of us get, and you've obviously explored and investigated this at far, far greater depth than I have, but the further you get into exploring what was actually discussed and talked about and evidenced in the trial, the wider your eyes get. From obviously me from the medical and obstetric and neonatal perspectives, but clearly now we know the deficiencies in the police side of it and the legal side of it. But the further I get now, I'm also sort of thinking about, but what about the bits that appear to have been deliberately kept out of the trial? So the grievance was discussed, but high and not in the level it would have needed to be for the jurors to realise that, actually maybe there was another reason why these consultants wanted to nail and scapegoat and victimise Lucy Letby. But then there were other things. There were the RCPH report, which was barely touched upon. There was this bizarre anonymisation of some of the main players in it, and we'll come on to that again a bit later in a discussion about one of the clinical cases, and then the main focus that we'll go on to in a minute about the Noah Robinson case, which was wasn't even mentioned, even though, and I think I'll hopefully be able to convince you and anybody watching later that just the chronology of when that case happened and what it involved, were absolutely highly relevant to the indictment cases, and I just cannot comprehend how any decision could have been made that actually no, that's not relevant. We won't let the jury know about that. Well, why? It was fundamentally important, and perhaps more so in the fact that, because when I started to look into the Noah Robinson case, I thought, well, maybe this happened before Letby started working there, but it wasn't. So clearly, in a way, that makes it more powerful, because clearly they must have. I think we can be fairly sure that if there was any possibility that they could have at least pinned some of what happened in that case onto Letby, that they would have done. So presumably she was off that week that case happened or something. She wasn't anywhere near it. Otherwise, I'm sure their willingness and keenness to include details of that case would have changed that decision.
Mm.
So the grievance is I think hugely significant, and I'm sure any healthcare professional knowing the details of that would agree with me that was an incredibly rare achievement for a junior nurse to win a grievance against two senior consultants, in the way still in the NHS that hierarchical relationship between different departments and different tiers of staffing operates. It was a hell of an achievement for her to submit that and to win it.
Yes. So I want to make a comment on the court case, and then I just want to ask you a follow-up question. So I think when you reflect on it, and the more that I reflect on this, what the court case should have been, of course, there shouldn't have been a court case in the first place, but leaving that issue aside, if there was a court case, what the court case should have been was, here is one explanation that Lucy Letby did all this malfeasance, and that is put up against this other explanation that there are naturally occurring reasons for what happened to these infants, because of the context of the hospital, because of the context of their clinical signs, because of the context of the mistakes that were made. But what actually happened was, the prosecution said Lucy Letby is guilty of malfeasance, and the argument against that wasn't there are other explanations. The argument was, well, you can't prove that.
Mm.
And that's not good enough. It wasn't good enough, unfortunately. Even the prosecution case is so weak, it was good enough for several infants. But if they'd have heard everything that we know now, I think it would have been completely different. Well, I'm certain it would have been completely different. And then the
And
follow-up.
I think
Hang on.
I completely agree with that, Chris. And I think, that I think that the frustration of, and you're absolutely right, that is exactly how the case went. And I think that would be quite hard to comprehend if the NHS wasn't in the mess that it was in at this time. But if you add on to that fact that, you had, because you know, our school of thought in why this went so badly wrong was the fact that the jurors were not given the opportunity to say this wasn't just one nurse that was murdering these babies. This was a failing unit. So the Countess of Chester had fundamental systemic issues, of which there were many. And look around the country, because at the time this happened, even then you could have said, well, look, we've got Morecambe Bay, we've got Shrewsbury and Telford, we've got East Kent, and then probably Nottingham and what followed on from that were a bit later. But there was ample evidence that elsewhere across the country you had departments that were having awful series of clinical outcomes that became maternity scandals, if you like. And people come back and say, oh, yeah, but those were maternity cases, not neonatal. But there was a significant overlap in most of those cases, certainly in several of the maternity scandals, that there were concurrent neonatal issues as well. And the fact that didn't even enter the equation, that those jurors weren't able to make a potential comparison between what was going on in those units, where there was an acceptance that was a department sort of trust-wide crash waiting to happen, if you like. But then they weren't given the opportunity to make that judgment that the Countess of Chester, where, to you and I now, and I think most people that have looked at this more globally now realise that it's blindingly obvious that was what was going on. And you see even now, there's been a couple of annual reviews of all the hospitals, and Countess of Chester right down at the bottom. There was another grading from NHS England that I think got into the media. Was it on Friday, I think, where they looked at, I can't remember what the terminology was, but the Countess of Chester was one of the 14 worst, and it's something to do with the way management dealt with problems. And Countess of Chester were on that. So clearly it's an organisation that have got systemic problems. But rather than accepting that, somebody just said, oh, no, murderer, and then conducted a 21st century witch hunt. And the way the trial was conducted was specifically designed to facilitate that.
Yeah. And the follow-up question I wanted to ask you as well is that you did talk about this, but I just really want to emphasize this. I believe this to be the case, but then you told me about this as well. Dr. Chris Green, who is chairing this grievance, is going to come under enormous pressure to side with the consultants. Isn't that the case?
I would, from my own experience, yes. Because I would have thought that somebody in the senior management organisation is going to think of the ramifications if it went any other way. And we've got evidence from some of the documentation later on that, I mean, again, and I suppose I viewed some of the documentation with the benefit, if it was a benefit, of having passed what I went through with my trust. But there was documentation at one point where they recruited the legal expertise of their in-house counsel, and it was perfectly clear from the way this email was worded that they were looking to make the working conditions for Letby so unpleasant that she would resign. And it was quite clear that this counsel, who presumably was the person they went to for advice on employment matters, was looking at the possibility, the worst scenario then could be that she comes for us for constructive dismissal, which, as I know only two, I didn't go down that route, but I was kind of warned against it, in that to actually succeed in a constructive dismissal claim is incredibly unlikely. From the trust perspective, though, it would be dead easy, because even if she had, so if you managed to get support from her unions and they supported her in that, the way a constructive dismissal works, which the trust would have known, and it was in this email, they were intimating, because she was, relatively low grade nurse, that she would be in for peanuts for compensation. It would probably be, well, certainly be less than £100,000. But then there was a caveat to it that they obviously realised that they had to be careful in that she didn't go for constructive dismissal on the basis of whistleblowing. Because I think we've discussed this, and I saw one of your recordings recently where you discussed the chat that we had about whether or not Lucy Letby was a whistleblower. And I stand by what I've always said, in that I don't think she realised, but she was a whistleblower. She whistleblew about standards of care, and she whistleblew about the consultants, and her grievance, in a way, you could say that was done in the public interest, and she was raising concerns about the clinical standards of the consultants, but also the way that she was being managed by the consultants. So that it would be pretty easy to argue, I think, that in itself was an example of whistleblowing. But the trust would have known that if, with her union support, she came back at the trust to say, well, I've been constructively dismissed, and that was on the basis of whistleblowing. The importance of that is, from the legal perspective, is it removes the financial cap on what you can claim. So you can really go for it if you can claim that you were forced out of your job because of a whistleblowing episode. So yeah, the trust knew, and the trust, I think, would have done everything possible to have prevented her from having more leverage. And I think the grievance would have been, probably the best example of that, because to go into any sort of employment dispute, or even, she never got near it, but an employment tribunal dispute, to have won a grievance, so an internally investigated grievance against consultants, and to have won it, would have been an incredibly powerful thing to have had on her side. And they would have known that. So I would have been amazed if Dr. Green from pharmacy hadn't have been pulled into office to say, be careful, do the decent thing, chap.
Yeah. So, I mean, I obviously, I thought that was likely. And I think even if it's not that kind of explicit pressure, obviously Dr. Chris Green is not naive. He will consciously and subconsciously know what the consequences would be of coming down strongly on Lucy's side. So that makes it even more extraordinary. And then the other thing as well is, it's just Lucy herself against everyone else, basically. I mean, the nursing team stood up for her, which is great, but they had any number of consultants in the process who obviously are against her, and yet she was completely vindicated. And I do think, and I know you've kind of mentioned this already, but this paragraph that we have at the end, where Dr. Green says Brew and Jerry should face disciplinary measures, essentially, that's the strongest indication we've had, documented indication, that they could have thought, right, well, it's her or us at this point.
Yeah, and they would have, they would have realised what that meant. They would have realised that, because all of this stuff, as far as a consultant is concerned, is, that would all have to be discussed at your annual appraisal. It'd be part of your GMC revalidation that you'd had a grievance against you, and so they would have known that, and that was the last thing in the world you would have wanted, and it would have affected your what I call CEA application points, which are sort of additional briefly bonus bits you get for your salary. So absolutely, they would have realised, and of course, what came on from this was later down the line was that they were threatened with having to do mediation with Lucy, which I think was at Brewery point blank refused to do. So that could have developed into something pretty nasty, because if a grievance goes against you, then there's part of that. I mean, because I had all this in the nonsense I was put through, and the trust will set stipulations about what you have to do to sort of get signed off to allow you to then go back to work, which the hoops I had to jump through. and they're non-negotiable. I mean, you can't say, well, that's thanks very much, but I'm not going to do that. Otherwise, you won't be allowed back. So I had to go through mediation. I had to go on a communication course, which was for my penalties, if you like, for having complaints against me that weren't upheld, but they still decided that was what I had to do. Those are the hoops I had to jump through before I went back. So you can imagine if who knows if they hadn't pursued Lucy Letby for the murder of these cases, and if she wasn't then kicked out of the department and effectively suspended for the police investigation, who knows what would have happened with this. And of course, from the other aspect, as far as the trusts are concerned, is the last thing they managerially would want is a precedent being set. Because you can imagine if what had happened to Letby hadn't have happened, and if she'd have come back to work or even left and gone to another trust and worked elsewhere, once the word had got out that as a junior nurse she'd put in a complaint against consultants and won it, that could have opened up the floodgates. Because you can bet your bottom dollar that there are issues with other consultants in that trust other than in the neonatal department. So once the word had got out that a junior nurse had won a grievance, then the trust would have been absolutely cacking themselves about, well, hold on, what's going to happen in other departments? So that would have been the last thing in the world the trust would have wanted. It was a monumental achievement. That grievance, and to have won it, and I think it was massively underplayed, and I think that was critical. I can just imagine when Bri and Jaran were told that she'd won that grievance, how that would have gone down, and when the language in that office would have been blue. And if ever they, where were they at that point in deciding what they were going to do? But if they were sitting on the fence as to whether or not they were going to scapegoat and victimise Lucy, that would have been absolutely perfect stimulus to have pushed them over the edge, to get them to have pursued her and to have made the call to the police.
Absolutely. So the next thing we're going to discuss, as you mentioned yourself, is the Noah Robinson case. So I think people will be broadly aware of this. This was an infant that sadly died at the Council of Chester Hospital due to mistakes made on the unit. So what we're going to discuss, what Martyn's going to go over, is the parallels between this case and some of the cases from the Lucy Letby case. So he has prepared this, so I will say very little for quite a while now as Martyn goes over this information for you.
Okay, thanks, Chris. Yeah, so those of you that are watching this, I'm sure, will be only too well aware of the cases that Lucy Letby was charged for and the clinical aspects of the case. And I think what has come to light, I think probably more so with Chris's and others' work about what's been going on since the judgment was made and Lucy Letby was put away on the 15 life charges, is that there was a very, very tight time period that the police were interested in the cases. And there's huge question marks about why that was. And I think what's become more clear over the last couple of months is the time period after the indictment cases, because there have been several sets of parents that have come forward with potentially very, very significant incidents that happened to their babies after the time that the police are interested in investigating. And these are some injured babies and some dead babies, but they weren't investigated for whatever reason. I think what people are probably less familiar with is that this happened at the other end as well. So there were cases outside of the approximately year-long period that was investigated by the police and Dowie Evans. And perhaps the case that's been most publicised was the tragic case, as Chris said, of this little boy, Noah Robinson. And it's a case that I heard of some time ago, and I knew the fundamentals of it, but it wasn't until recently where I think somebody posted a couple of the local press reports in Chester when this case happened, and then when there was a coronial investigation into the case, how the coroner concluded. And so I started to dig into it and got interested in it, and did a bit more research myself. And again, it was another one of those instances for me, and there's been several of them throughout my interest in the Lucy Letby case, where the more I looked into this, I thought, hold on a second, this is pretty major. So I thought it was worth. I put a post about this on social media a few weeks ago, and I thought it was worth probably trying to draw people's attention to it more in this forum today. So I'll just quickly go through it. So timing wise, I think it's fundamentally important because this case happened almost exactly a year before the cases that Lucy Letby was investigated for. So just 12 months earlier. And of course, that's important because if there are aspects of what happened in this case that are irrelevant in any way to any of the Lucy Letby indictment cases, it's relevant. But also, and this will become perfectly obvious as I go through the case, particularly the coronial judgment on this case, you have to really question, because if a unit, the modern NHS for many years now has all been about learning. It's all been about, there's an acceptance that anybody can make mistakes, and doctors and nurses are no different from anybody else. But the NHS has supposedly been running on this sort of learning culture, and then the basis of that is from the clinical governance perspective, and that if you do get suboptimal cases, it's beholden on the individual who was implicated in the problem, the error of judgment, the error of practice, whatever, to learn from that, to accept it, to hold your hand up for to be duty of candor to the parents, and to make changes both on an individual and organisational basis that will minimise the chances of the same error, mistake, deficiency, negligent care from happening again. So that's a critical part of the learning culture, that yes, we had this problem with Noah Robinson's case, this is what the errors were, this is the person that was involved, we've accepted this error, this is what we've done about it, these were the changes that were brought in to prevent this from happening again. So yes, this happened a year before the indictment cases, but then you have to take a step back from it to say, well, okay, what was learned from it as both individually and as an organisation, and how confident are we a year or 18 months later that sufficient lessons were learned on an individual practitioner's basis and as a department to prevent this from occurring. So just keep that in the forefront of your mind as I go through. Because I think there are significant alarm bells that should have been ringing with this case, and then why the decision was made that this was completely kept out of the trial, I don't know. Letby was working in the department because she was there a couple of years, I think, before the Noah Robinson case. One can only assume, because I think we can be fairly sure that if she'd have played any role in the management of this case, that it would have been brought into the trial. So one can only assume that she wasn't anywhere near the unit when this case happened, but I don't know that. But it's the only thing really that would make plausible sense for me. So Noah Robinson was premature, and the clinical deterioration of this case necessitated, when he became unstable, the placement of an endotracheal tube. So for those of you that aren't medical, some of this will start to ring bells automatically with some of the cases in the Letby case. If any human being, but particularly a vulnerable neonate, becomes unstable or unwell and is unable to maintain their blood oxygen level, cardiovascular status, then they may require assistance with their ventilation. So that can be done using either a little face mask, sometimes using CPAP, which is a positive pressure breathing, or at the top end, you can actually take over ventilation for them using an artificial ventilator. And to do the latter, you require the placement of an endotracheal tube. So these are small plastic tubes that go in through the baby's mouth, round the back of the tongue and into the, ideally where you want them, but it's critical, is to place them in the trachea. Now, the anatomy of that part of our bodies, and particularly neonates, is quite tricky in that you have, essentially, to simplify things, two openings at the back of the throat. One of them is where you want the tube to go, which is the trachea, and the other one is where you don't want it to go, which is the esophagus, which is the food pipe. And without going into all of the details, the team, and it was a consultant primarily involved, the care of Noah Robinson, who was developing gastrointestinal problems thought to be possibly necrotizing enterocolitis from my understanding, but needed to have an endotracheal tube placed, and this was undertaken by a consultant. And the problem was that the endotracheal tube, and this is where an alarm bell should be ringing for anybody who studied the other cases in the Lucy Letby indictment, is that the problem with this case was that the endotracheal tube was misplaced. So rather than going into the trachea, the endotracheal tube was placed in the esophagus. Now, obviously, if you're ventilating a baby and all the clever stuff from the machinery is expanding the baby's esophagus and stomach and not the baby's lungs, you aren't going to help the baby. In fact, you're going to make it a whole lot worse. Now, I'm not a neonatologist. My memory of neonatal ventilatory issues is very, very old. I'm 3 decades old. But when this case went to coronial investigation, there were apparently 5 different signs. So from that, there were readings, from my understanding, in the ventilator, and also from the other monitoring of the baby. There were 5 separate signs that the endotracheal tube was in the wrong place, but none of those was acted upon. So I think some of them were recognised, but I think the consultant and the other members of the team that were managing this didn't act on that. So they assumed incorrectly that the tube was in the right place. So didn't take it out, didn't try and replace it in the trachea, but they carried on, and the baby deteriorated and eventually destabilized to the point that the baby ended up having, I think, a massive bleed in the lungs, which then was the final event, and that's normally produced by a combination of prematurity and hypoxia, so not getting enough oxygen. That meant that the baby tragically didn't survive and never made it to the receiving unit, where the baby was meant to go. So of course that episode of misplacement of endotracheal tubes is consistent with some of the cases in the Letby indictment. Chris himself interviewed a paediatrician just about 6 weeks ago, I think. I can't remember her name. But it was very interesting for me to listen to that, because I'd looked into the twins A and B cases, but obviously without a neonatal background, I hadn't really looked at the aspects of the actual collapse, in inverted commas. But her detailed assessment of that case was that well, did baby A actually collapse, or did that baby have an apneic episode? And then her view was that the collapse was caused by a failed intubation. So an intubation where the tube didn't get into the trachea, but was placed in the esophagus, which is exactly the same as what happened in this case. And that case aside, I mean, obviously that aspect of twin A's case wasn't discussed in the trial, to my knowledge. But there was plentiful discussion in several of the other cases about difficulties with intubation. And Chris's memory on this would probably be greater than mine, but there was one case where I think there were 7 to 8 attempts putting an ET tube down, which is just astonishing. So, you know,
before I go any further, can you just explain why that's so bad?
Well, I think, we've discussed it before, and one of the other times we've chatted, I think there is ample evidence throughout all of these cases to question the skill, the level of training, the competence in that neonatal unit at, you know, what I think most neonatal units would view as basic interventional procedures. So by that, you know, I mean the ability to intubate babies. By that, I mean the ability to be confident in the placement of IV lines. I'm not necessarily just talking about peripheral IV lines, which can be tricky in babies with minute veins, but I'm talking about central lines like umbilical venous catheters, and particularly long lines. So there's several cases where these lines were put in, they had to be resited or replaced. And probably the most notable example of a query about the competence was in triplet P, the baby that had the pneumothorax, which again, the theory being from that, maybe that was a ventilation problem in the pressure septae, which caused the pneumothorax. But then the poor dad witnessed the doctors present on that day looking how to insert chest drains, which is obviously the treatment for pneumothorax, up on Google. So there was obviously a computer in the neonatal unit, and he witnessed them looking up how to put in a chest drain. So with ET tube placement, it's all about, all of us, Chris, we pass through various stages of our medical training, and part of becoming a consultant is learning the tools of your trade. And I used to love training juniors when I was a consultant, registrars or then registrars and senior house officers. It was immensely satisfying, but there comes a point when there are some cases that are technically so challenging where well, I think actually, to be fair, I ought to do this case because we're only going to get one attempt to do this. So if you don't mind, I'll do this, and I'll train you rather than you do it, and I'll watch you and guide you. But in a lot of more standard cases, part of the training of junior doctors is to allow them to do increasingly challenging cases as part of the learning curve. But there has to be something seriously questionable in a department where, for something as critical as putting in an endotracheal tube, it takes 7 attempts. Now, I don't know who tried episodes 5, 6, and 7 to finally get it in, but one would hope that was somebody at a consultant level. But if a junior doctor is attempting something and they don't succeed once, I suppose it's reasonable for them to have another go. But if it's something as important as getting an ET tube down a premature neonate to give them oxygen, then I'm astounded that it could take 7 or 8 attempts. So then you worry about the level and attendance of consultants on that unit when things needed to be done. What I think it was with triplet O, it took the consultant during normal working hours 39 minutes to attend. Well, that's too long. That's 10 times too long. So what happened in that 40 minutes? Was that 40 minutes multiple attempts by a junior doctor to do something? So again, it's a huge question mark, which I've had from a very early stage of my interest in this case about actually how competent were the doctors in that unit at doing these procedures. And the thing that the corollary of that is moving on to, well, if there were issues with those practical procedures, how confident are we that in the basic resuscitation skills in that unit they were up to scratch as well? And I think that's very relevant for this case as well, because that would be, I think if there are issues with basic practical procedures, I would question how confident we are that the resuscitation, which is a very structured routine of different procedures to try and get a baby back, how confident are we that was done in an exemplary textbook fashion?
Yeah.
Sorry, go on, Chris.
All I wanted to say was someone who is very, very qualified told me recently that if someone failed on like a couple of intubations, they'd just be like, right, you can't do it again. Even if it was a consultant. Do you think that's fair? And nurses as well told me, and I'll put this in my book, it's like you fail a couple of times, it's passed on to someone else. That's it. Would that be normal practice, do you think?
It would depend on the case and the urgency of whenever you're doing a clinical procedure, and we're focusing on ET tube placement now. Whenever you're doing clinical placement, the amount of time that is taken before you secure and complete that procedure depends on the urgency. But by definition, with a premature neonate, if you've got to get an ET tube down, that's because you want to get the baby's oxygen level up. So that has a finite time period, because the cells in the body, and particularly the brain, can't survive for many minutes without oxygen. So, you know, it's, I think having spent, you know, decades of my career, particularly latterly training juniors, it's actually quite a tough thing as a consultant to say, can you stop? I'm going to take over now. Because that's a huge kick in the pride and the teeth of the junior. And then, you know, the next time when they're in the same position, they're going to be nervous about doing it. But it's part of growing up, if you like, as a trainee in medicine. And most trainees, you know, some trainees are exemplary. You teach them once, they do it, and then they can almost teach it from thereafter. Other trainees, it takes a good lot longer. It's all about, you know, everybody's different, isn't it? Everybody obtains competency at different rates. But certainly in this sort of situation,
if I was a doctor, that would be my. I mean, thank God for the people I'm not, but that would be my concern. Would be, you know, I'm not that great with my hands. I was good at hitting a ball, but that's my only, you know, I'm not. I could easily see I would be rubbish at intubation. You know, and I think, I mean, when I talk about this, I do. That's why I like to have someone like you on. One of the many reasons. I always try to be fair that I've never been in an operating theatre. I've never had to, you know, we talk about these things. You can do it because you've been in that situation. I always try to be fair and not talk about these things. Oh, you know, they just had to do an intubation, or they just had to do this, they just have to do that. I mean, it is pressurized, difficult work.
yeah.
And I just kind of want to be clear on that because.
But it's horses and courses, isn't it? I mean,
Yeah.
I used to, you know, when at the peak of my clinical time, you know, just before I finished, you know, nothing used to excite me more than doing, you know, complex high risk cesarean sections. You know, so some of the most time critical, potentially bloody procedures you could get used to, you know, be my bread and butter. And yet you give me a drill at home to put up a picture, where I've got to, you know, put a drill through, where I knew damn well there was not going to be any tubes or pipes or anything behind the wall, and I would get into a real state over it. So it's horses and courses, isn't it? But it's all about, and I was very, very fortunate that I had some brilliant training posts when I came through. So and some surgical mentors that I was very fortunate to train under, who were very patient and, you know, brought me up to speed. And I, you know, to my final day operating, I still had some of my old surgical mentors that I used to sort of imagine sitting on my shoulder when I was doing procedures, whispering in my ears about where to incise the uterus or what have you. So it is. I think part of being a senior surgical mentor, if you like, is knowing when the time is right to say, look, enough is enough. Can I take over now? Because it's, you know, particularly in time critical surgical procedures like cesarean sections, where, you know, mums can lose a hell of a lot of blood very quickly. It is critical to say, no, you know, enough is enough. I'm taking over now. But then you know, you need to treat trainees with kid gloves, knowing that that's, you know, a bit of a kick in the teeth for them, and then, you know, you need to give them a bit more laterality in the next one to build their confidence up again. And but even as a senior, the thing I always used to feel with surgical procedures is complacency, because you could bet your bottom dollar if you go into a surgical procedure, and the cesarean section being probably what I did most of, and you were cocky and complacent, you would come unstuck.
Yeah.
And it would often be the cases that you were least expecting. You know, maybe a breach or something that you think was going to be dead easy, and you go into it all cocky and confident, and something horrible would happen, unpredictable. But part of being a senior, experienced surgeon is spotting that and knowing what you need to do to get yourself out of that, really. And I just wonder. I mean, again, it's all down to, you know, it'll start to sound like a stuck record scene about having access to the full clinical records of these cases, but I think once, if they ever are, the full clinical records come out about these cases, to know who exactly was present for, you know, for these cases when the 7 intubation, who did tries 1 to 6 on the intubation, and why did it take that long and so many attempts. It might have just been, to be fair, in that case, it may have just been a hideously difficult intubation. It happens, but it may not have been. And it just seems to me with all of these cases, there were, the amount of lines that needed to be replaced and recited, infusions being given through lines which were in the wrong place, the wrong doses of adrenaline being given. There's too many things that should be completely straightforward and standard that were being screwed up. That does concern me.
Just park that thought for a second. So I just need to let my dog in. Just listen. Come on then. Come on then. I'm not editing this out, by the way, if you're watching this on YouTube. My cleaner's been looking after my dog, so she's gone now, so he keeps wanting to come back in. So please continue.
Yeah, so the other thing about one of the press reports about Noah Robinson's case that it kind of breaks heart really is when you read the statements from the parents, because they were in a way, and I get this, it always happens whenever anybody tragically loses a baby, but it sounds like they're almost punishing themselves. They were, we put our trust and our faith in the consultants and the people looking after them, and maybe we shouldn't have done that. So they're almost blaming themselves for doing, what option did they have? And that's the whole thing about being in a hospital, isn't it? Particularly where you go home of an evening and you leave your amazing, lovely little baby.
I guess you have these thoughts of, should we have gone to another hospital? Should we have gone private?
Yeah.
Be a very natural way to think, wouldn't it?
So then going on, and this is again where it sort of rings startling alarm bells with the Lucy Letby indictment cases. The other things the coroner criticised with the Noah Robinson cases was that blood tests were done and X-rays were undertaken, but they weren't looked at. So it's, you often find with clinical negligence cases and serious incidents that when you actually dissect what happened, you normally find a whole series of errors, and it's often when you get into the nuts and bolts of what goes wrong, you'll often find that the first sign of things going wrong were the very basics being missed. And the thing is, in any clinical scenario, you ask, if you're trying to work out what's wrong with a patient, you take a history, and obviously that's different with a neonate. You examine, you use your clinical skills to examine something, and you do special investigation, and that will fall down because there's a classic thing when you're learning to be a doctor. There's no point in just doing special investigations if you don't take the responsibility of looking at the results. And that happened in Robinson's case, that blood tests were done and X-rays were ordered that weren't looked at. And then there were condemning things that again ring very true with what's come out in the Letby cases, of there being major issues with staffing at the time. It was perfectly clear to the parents that there weren't enough nurses around to care for the vulnerable neonates. Even they noticed that the middle grade doctors, because I think the middle grade, or what are they called, resident doctor now, positions in that department, I think must have been a nightmare, because they were clearly stretched between two sites, or three sites. They were covering the neonatal unit. Part of that would have been covering the labour ward, and they're also covering the paediatric ward, all of which are three different sites. And that can only work if you've got good attendance support from consultants. And that's where I think it fell down, in that I don't think these guys were given, particularly out of hours, I don't think they were given appropriate levels of attendant consultant support. And there was enough from, was it the RCPH report, and I think it came out in Thirlwell as well, that there was some of the consultants that the juniors were very hesitant to phone because they knew they wouldn't get a receptive response if they needed help.
Yeah. So, why is this not in the court case?
I don't know. Because every single line of the coroner's judgment on this, I thought, well, hold on, that's absolutely relevant and pertinent to and there's more coming as well. So the clinical background of Noah Robinson's case, the reason he was delivered early was it was identical to the twins, A and B. So the mother had preeclampsia. So again, for the non-medically informed viewers out there, preeclampsia is a pregnancy-specific blood pressure problem. So you don't get it outside of pregnancy. So, and it presents with a combination of high blood pressure, protein in the urine, which is why when every pregnant mum has an antenatal clinical midwifery appointment, we're obsessional about checking their urine for protein. and they become swollen. They get what's called peripheral edema, so they get boggy ankles that when you press on them, you get dents. So both of these mums had preeclampsia, and they also both had something else which was identical in that they had what appears to have been the gross misfortune at the Countess of Chester Hospital, in that they had the ignominy of being delivered out of working hours, which I just find astonishing. Again, from something that the coroner said in this case, you get the impression that there was a view that you were at greater risk at the Countess of Chester Hospital if you dared to need any clinical procedures done outside of normal working hours. So in other words, you would get a safer and preferential standard of care if you could just time the need of an intervention or a delivery between 9 o'clock in the morning and 5 o'clock at night. In other words, woe betide you if you needed anything done after 5 o'clock in the evening, and God help you if you needed anything done at weekends or bank holidays. And that's just remind me where we are at the moment. This is the 21st century, and we're in the United Kingdom. And the Countess of Chester Hospital is a unit that was supposedly providing pretty much full obstetric care, and at this time, level 2 neonatal care. And yet there is evidence that substandard levels of care were being provided to mums and babies if they were delivering in the evening or at weekends or at bank holidays. And that's just astonishing. And that was the same in both of these cases. So Noah Robinson was delivered, I think it was at a weekend, as were twins A and B. What were the other things? Yeah, the other issue, of course, is, and this is where I need to be a bit careful, but it's the issue about who was involved with these cases, because the coroner was rightly critical about the consultant who was responsible for their handling and principal management of Noah Robinson. And this was all in the judgment, and there were criticisms made, and advice was given about what I was saying right at the beginning of this part of our discussion about learning from this and doing all you can to prevent it from happening again. So come forward 12 months, and the consultant who was involved and criticised heavily, appropriately, in the Noah Robinson case was directly involved with some of the Lucy Letby indictment cases. And for reasons that I don't understand, the decision was made that consultant would be afforded anonymity in the trial. Now, whether that was to prevent anybody from putting their name into Google and finding out that they were involved with this case, I don't know. But is it not relevant? To my mind, it's relevant from what I said at the beginning, in that it has to be gravely concerning for any clinical unit in the NHS if there's apparent lack of a learning culture. So if this consultant was heavily criticised for the avoidable death of Noah Robinson, and then a year, 18 months' time, they are potentially causally implicated in further suboptimal outcomes of babies, you have to question what happened in between. Now, you would hope after the Noah Robinson case that the trust put out statements, as they always do, or we've learned from this and measures have been taken to prevent this from happening. Well, I would dearly love to know what those measures were. And you would have expected, if a consultant was criticised for this sort of thing, you would have fully expected evidence of detailed appraisal of what that person was put through as a consequence of that first case, to re-educate them, to put them in supervised practice as far as tricky intubations were concerned, and for them to have a sign-off as to when they were signed off by a more senior experienced consultant about when they were able to go solo again. And did that happen? Was there evidence of annual appraisals of the junior doctors? Because that should be a critical part of every practicing doctor's annual appraisal, working in an neonatal unit, that they're signed off for this sort of thing, and critically for resuscitation training. Did that happen? It may have done. It may be completely textbook completed and all signed off, but we don't know that. And that's, for an organisation that had a case like this a year before the indictment cases, and then a year later, very similar things happening again. There are red flags, red bells ringing for me about whether that's a department that genuinely learns from their past bad experiences.
Yeah. So, do you have anything to add to that, or is that everything you have?
I guess the way I would end that was how the coroner summed up Noah's inquest, really, because he made the statement that that Noah died. I'll quote him. So I got it on my computer screen here whilst we're talking. And he quoted that Noah died from an unintended consequence of an intended event, which was quite a concise way of summarising what happened. That it was the intended event was the intubation, which went wrong and was put in the wrong place. But it makes me wonder how many of the Lucy Letby indictment cases were caused by unintended consequences of intended events. Because to me, there are startling similarities from Noah Robinson's case to very many of the Lucy Letby indictment cases. Yes. So I can't compute why a case which, to me, and I think everybody reading that or listening to that, will say, well, hold on, this is almost identical to what happened in several of the indictment cases. Why was this completely kept out of the trial and from the jury? I don't get that at all.
Yeah, and there is very little coronial discussion in court, even regarding the cases that are actually. There's a few bits and pieces where a couple of things are mentioned. So you could at least argue that the court heard there'd been coronial reports and there'd been pathologists, but I still cannot. It wasn't properly conveyed. I mean, I think I do. Again, this is yet another area where the defence should have said, "Look at all these reports from people who actually examined the infants." And they don't appear to have done that very much. There are things it's mentioned, but it's never like a. I mean, I'm looking at the complete trial now. There's 24 mentions of the word coroner, and all they are. So the first one is the case was referred to the coroner, and the cause of child's A death was unascertained. That's it. The coroner gave the cause of death as pneumonia with acute lung injury. This is child D, where it blatantly is. That blatantly is the cause of death. There wasn't a post-mortem. The consultant did not deem one necessary. The coroner's office agreed. This is child E, where there should definitely have been a post-mortem. That's it. The cause of death was given by the coroner's hypoxic ischemic damage of brain and chronic lung due to prematurity, which was. Anyway, so it goes on. So there was mentioned a few times in the court case, but it was just, the coroner did this, that's no relevance. Let's carry on with what we. So I don't know.
And I think with your encyclopedic memory cases, Chris, you'll know better than me. But I remember several times when I was looking at the cases, I thought, God, this looks very convenient in the timing at which this case was referred to get police involvement. It just seemed very coincidental to me that it was done at a time where it prevented coronial investigation. Yeah. And that makes me very suspicious because. If you think of the level that the coroner looks into Noah's tragic loss, I don't think the consultants in the cancer suggest that. I think they realised that there was far more likelihood that they were going to come unstuck with a police investigation of the cases than if the coroner had been involved. So I think the timing of the moving these cases, oh no, these are now and being investigated by the police. So we'll cancel the coroner's hearing. That may have been coincidental, but I have a funny feeling it wasn't.
Well, I can't really add anything. Obviously, I don't know for sure. Um, I mean, I always have questioned why they were so hell-bent on the case going to the police when there should have been, very obviously, there should have been a more thorough medical investigation into these cases. And it is phenomenally unlikely, like 0.001% chance, I would say, that such a medical investigation would have concluded that Lucy Letby was to blame for what happened. I think only the investigation of Dr. Evans could possibly have drawn that conclusion.
Mm.
I don't think any other qualified medic anywhere in the world would have come to the conclusions that he came to, apart from Dr. Bowen, of course. So that kind of concludes our discussion of Noah Robinson. I'm just going to ask you one question to finish. I've got 11 pages and few questions that we will get to with Martyn over the months and years to come, because unfortunately we don't think this case is going to be resolved this year, and it would be optimistic to think that it will be resolved next year. So I'm sure we'll have Martyn back many times, and we'll work through these questions. Another thing to consider, as I mentioned previously, is once this case is referred to the Court of Appeal, what I do on this channel may have to change significantly. I don't know what I'll be able to do, and I don't know what I won't be able to do, but that will be a good time to ask general questions about that are not specific to the Lucy Letby case. But I do have one question I want to ask you, because I wrote this question myself.
Go for it.
I personally have been surprised by the extent and scale of what seems to be a cultural crisis in the NHS, which encompasses an undesirable general atmosphere, bullying, and an unhealthy hierarchical culture with no protection for whistleblowers, among other issues. Do you have any reflection on this, and can anything be done to improve the situation?
Wow. How long have you got?
Just speak for as long as you need.
I mean, obviously, that question aimed at me in view of what happened to me in my career. I mean, I've got a very cynical, well, appropriately cynical view of whistleblowing, and certainly the position it puts you in as a whistleblower. Theoretically, in the NHS as it stands at the moment, members of staff are encouraged to raise concerns, and whistleblowing is promoted. So all NHS trusts will have what are called freedom to speak up guardians. So there'll be somebody normally in every department who is taken on by the trust as a freedom to speak up guardian. So these are supposedly the people you go to as any member of staff, be you a cleaner, a healthcare assistant, or a consultant, to go to raise concerns. So as far as whistleblowing legality is concerned, for your concern to be viewed as an actual formal whistleblowing event, and most people don't understand this, I certainly didn't understand it when I did what I did, you have to be a sort of a nominated person to be able to do that. So I was okay with mine, because when I raised the concerns that I raised, which were essentially, without going into all the details, I raised patient safety, maternity patient safety concerns, and I raised concerns that have been raised to me by midwives regarding what they felt were unsafe staffing levels. And I raised those concerns with my line manager, so it was our head of service, who was the director of midwifery at the time. So that was an appropriate thing for me to do. The problem with that is, though, is if you're whistleblowing concerns with a nominated person, that person is employed by the trust and will very commonly report to the very manager that you're likely to be complaining about. So therein lies a huge problem, that they are conflicted. And that's where it all sort of falls down, really. So the things that are critical with whistleblowing is that you should, and all trust policies will include this, that you should be offered protection. So you should be offered complete anonymity. Now, I can say with absolutely 100% certainty in the whistleblowing events that I was involved with, pretty much as soon as I said what I said, my anonymity disappeared. Everybody knew. Everybody knew who the person was in our department that was whistleblowing. So my anonymity was non-existent. So the whole process is a mess, really. And then, of course, my case was pretty extreme, and mine developed into what tends to happen if you whistleblow and if you press the wrong buttons is the whole thing, as happened with me, will be turned around against you. So there is a almost a universally employed technique called DARVO, so DARVO. So if you raise concerns that are unpleasant and unpalatable to your seniors, the first thing they do is they will deny the problems that you've raised. So that's the D. They will then accuse and attack you. So that's the A. So they then come back with allegations against you. So mine was turned around. So after 30 years of exemplary service, 20 years at consultant level, exemplary appraisals, textbook GMC revalidations, all of a sudden I was faced with accusations of, as interesting the term you used, bullying, harassment and undermining behaviour by a group of senior midwifery managers, all of which were fabricated and were disproved. So all the stuff that the trolls continuously, as of even earlier today, accusing me of being dismissed for bullying, completely unfounded, disproved by the trust. So I was not dismissed for bullying. But of course, bullying is one of those things that is pretty much impossible to prove or disprove. And as I found out, there is a very, very, when you think about what I was raising concerns about, avoidably injured mums and avoidably injured and killed babies, it's quite difficult to say that in a very calm and balanced and tone, other than being seen to be assertive. And there's a very, very faint line between being assertive and being accused of bullying. So bullying is a very, very easy thing for challenged individuals to come after you with an accusation, because it's impossible to prove and it's pretty much impossible to disprove. And then, of course, my case developed into a grievance and all sorts of other horrible things. And then went to the employment tribunal. And theoretically, there's something called PIDA, the Public Information Disclosure Act, which should protect you as a whistleblower. But the problem is that there are highly paid employment lawyers and barristers out there, and NHS trusts and other huge behemoths organisations have got incredibly deep pockets for legal expenses, and they spend their careers basically looking into the finer points of legal practice that will enable them to challenge even the most black and white cases of whistleblower persecution and losing your job as a result of that, and claim that, as in my case, that I wasn't dismissed for whistleblowing, which I think anybody who was even remotely involved in my case will realise was a farcical claim, really. So it's a mess, really. So, and of course, from the trust perspective, it's self-perpetuating, because certainly in my trust and across the NHS, because I think my case was pretty well publicised, and having taken on the trust for what should have been a straightforward open and shut case and not one, it's a stark warning to every other member of staff. So, why on earth would anybody whistleblow when you can end up losing your career and your profession and your livelihood? Woe betide anybody else in my old trust and across the NHS who whistleblows, because it's, if anybody asks me, well, people have asked me would I do the same thing again, and I've always said yes, because I was placed in a position where I couldn't do anything but. But when people have phoned me for advice, I very commonly say just keep your head down, don't risk it, because it's not worth it. Most people who end up in the position I'm in, it's a well-paid job, and you enjoy a certain lifestyle, and as part of that, you're paying your mortgage, you're paying your bills, and you're paying maybe for your kids' education. And I was what happened to me was terrible, but it happened when I was 58, so I was very close to retirement age. But I've got friends and that I've made throughout this across the country who are in the 30s and 40s that have ended up losing their jobs in very similar circumstances. So it's a mess, and it has to be rectified. And I think it's one of the critical things that I hope comes out of the Amos review. And if there is an independent review into maternity, West Streeting needs to get up to speed with this and to realise that you can't keep persecuting people that are doing what is their basic professional responsibility and raising concerns and whistleblowing patient safety concerns. You're not going to improve outcomes unless you radically change how people in that situation are managed and handled by NHS trusts. So that was a long and complicated ramble.
No, it's a good,
I think the hierarchical thing you talked about, I think, is it's poles apart from where it was, Chris. When I think about what medicine was like when I started 30 years ago, where when I think what some of the consultants were like then, where you literally were quaking in your boots on ward rounds and you knew you were going to be richly humiliated. Those days of long and rightly so, because that wasn't really good for anybody. The problem that's come as a result of that, though, is the as soon as you take away the hierarchy, you kind of take away responsibility for what happens. I certainly saw that in maternity, where as the consultant, you're kind of the top of the tree professionally, so you are expected to take responsibility, but then decisions were being made at a lower professional scale to consultants, sometimes by senior midwives and also consultant midwives. And there wasn't the same, so they had the same title, they were consultant midwives, but they had nothing like the same level of professional accountability. So they wanted the responsibility that came with the job title, but they weren't prepared to take the accountability that should come with it. That's a whole other issue, though.
Well, yeah, very interesting to hear that. It's always educational for me. I mean, I'm learning all the time. I think I would definitely like to write about this in the future. Having said that, I don't want to think about doing anything else for a while. But I do think that there is something to be written about the whole whistleblowing field, and an issue. I think it's probably not something that's unique to the NHS, but it seems that it's a unique, nuclearly acute problem in the NHS. Yeah. So anyway, thank you very much for joining us again today. We really appreciate it. It's been very informative as always. And as I said, I've got 11 pages of questions for you. We'll have you back soon to discuss more in a couple of months or whenever. And yeah, thanks for your continuing input to this case, and I'll speak to you soon.
Let's see what the next few weeks unfold, Chris.
I mean, it's bound. I think we've got past the point where we think, it's going to go quiet. I mean, I think there's going to be more and more stuff happening now. I think the momentum is gathering now, and I think there won't be a lull from now on for quite. I think there'll be more and more stuff coming up. I think that's baked into the cake at this point. Yeah. Anyway,
enjoy the weekend. Cheers.
Yeah, you too. Have a good one.
Bye.